Hello, everybody. Welcome. We will start shortly. We're just going to give it a couple of minutes while we wait for people to join the webinar. So thank you very much. I hope you've all enjoyed that beautiful sunshine that we've had today. So I'll give it another 30 seconds. Okay, I think we'll get going. So good evening, everybody, and welcome to Heart UK's webinar on everything you need to know about LPA. My name's Jules Payne. I'm the Chief Executive of Heart UK, the cholesterol charity. Can I just remind you, you're not on camera and we can't hear you. So you can sit and have your tea if you'd like and do whatever. That's absolutely fine because we can't hear or see you. Just as a reminder, this webinar will be recorded and will be available afterwards on the Heart UK LPA webpage. And we will let you know through our e-news when that becomes available. We've had an awful lot of questions in advance of the webinar, which is fantastic. We've also got a lot of questions from our helpline that we'll be using today. So we want to make sure that we're actually giving enough time for questions. But anybody that's got questions this evening, if you could please put them into the Q&A, that would be fantastic. Thank you very much. And I'll try and group them because there's an awful lot. So what we're covering this evening is we're going to start with what is LPA. And then we'll go through the statement of care that Heart UK published in 2019 around LPA. That covers an awful lot of things and will hopefully answer an awful lot of your questions that you have as well. And then we're going to discuss what can people actually do about it, because that's what everybody really, really wants to know. And then we'll start the questions. So the questions will all be done at the end. So I would just turn to Dr. Neely and Dr. Cegla to introduce themselves. And Dr. Cegla, I'll come to you first, please.
Hi, thanks very much, Jules. So I'm Cegla, and I look after the lipid clinic. I'm a consultant in metabolic medicine at Hammersmith Hospital in West London. So it's a pleasure to be here. Thanks very much.
Excellent. And Dr. Neely?
Good evening. So I'm Dermot Neely. I used to look after the lipid clinic in Newcastle hospitals, which I've now handed over to younger colleagues. I'm a trustee of Heart UK, and I'm really working as an advisor on areas such as lipoprotein A at the moment.
Excellent, thank you very much. So before we start, I would like to run a poll to see where the knowledge levels are with everybody. So if I can just launch this and you can choose one answer, please. So I'll just give that. Okay. This is looking quite reasonable. So, yeah, I think I'm going to end that here. So I'm going to share results. As you can see, there's actually quite a few people on that are fairly knowledgeable, which is great news. But let's hope that we can improve that knowledge this evening. So, Dr. Neely, over to you. What is LPA?
Well, start with lipoprotein A, or LPA as we call it, is cholesterol, and cholesterol is the focus of Heart UK, as you know. most of the cholesterol in the blood is found on something called LDL, which most of you will have heard of. LDL is filled up with cholesterol and sent out into the blood from the liver. And some of that LDL will also pick up an extra little protein component, or like a piece of Velcro, which turns it into a lipoprotein A particle. Now, not all of us actually produce this extra little protein like Velcro, and therefore not all of us actually make lipoprotein A. It's a genetic ability or tendency. It's something that we are born with, and we inherit from our parents. So we either inherit the trait of producing this Velcro, which gets added onto the LDL to produce lipoprotein A, or we don't. Some of us produce more than others. And those of us who produce the highest amounts of this end up with a large proportion of the LDL in our blood having this extra Velcro-like protein on the surface, which makes it stickier and makes it more likely to attach to the blood vessel lining, where it will deposit its cholesterol, and less likely to be successfully recycled through the liver, which is what most of us want to do with our leftover cholesterol and LDL. So lipoprotein A is something that naturally occurs in many people, but it's only those people who seem to have the highest levels of this where it really causes a problem with cholesterol attaching through the lipoprotein A Velcro to the blood vessel lining to cause cholesterol buildup at an earlier age than we'd expect. So that's really what LPA is. I hope that's clear.
Excellent, thank you. I'm sure there'll be some questions. I realise I was just muted there. So Dr. Cegla, can I come across to you now to talk about the Heart UK Statement of Care on LPA that we published in 2019, to give us just the highlights, really?
Yeah, of course, Jules. So as Dr. Neely said, this is a particle that is floating around in our blood. Some people have a lot of it and some people have very little. And one of the problems is we've known about this for many, many, many years. And there have been quite a lot of trials and studies looking at it and its association with heart disease and other diseases. But one of the challenges that we've had is that measuring it has been really, really difficult. So that's really kind of impacted on the quality of the trials that we've had that have come out. And that's why it's not been as obvious a risk factor as some of these other risk factors like LDL and, blood pressure, smoking, and all those other things that we know that increase our risk of heart disease. So I think that's one of the things that have made it quite difficult for Lp(a) over the years for us to sort of really establish it and understand it as a risk factor. But I think, over the last few years, the evidence for it causing heart disease has become more and more strong. And as we get better at measuring it, we're just accumulating more and more data. We don't know everything for sure. There's a lot more to learn, but we feel that we're now sort of in a position whereby I think most scientific bodies around the world interested in sort of heart disease and risk factors that cause heart disease are sort of incorporating it into guidelines. And I think we were quite conscious at Heart UK as part of the medical and scientific committee that we in the UK didn't really have any guidelines to sort of explain to other clinicians about this sort of risk factor and what to do with it and how to use it as part of our clinical practice. So it was in 2019 that we decided to put together all the evidence, all the scientific evidence that had been accumulated, and come out with sort of a practical guideline to help clinicians sort of understand the evidence and also then sort of use that to guide their clinical practice. And we were quite conscious that it shouldn't be just for people like Dr. Neely and myself who spend a lot of our lives thinking about cholesterol and heart disease. It should be for GPs, cardiologists, vascular surgeons, stroke physicians, and really sort of something that can be used by clinicians across the board. So just to go into a little bit more detail about it, I think that what we tried to do there was firstly just show the evidence of Lp(a) as a cardiovascular risk factor, and go through some of the data that describes that in some detail. And then after that, we then looked at specific groups of patients that we felt would really potentially benefit from its measurement. And this is different across the globe. So, you know, so European societies have their own guidelines, the Americans have their own, but we felt in the UK that particularly, we discussed a little bit about the measurement issues, that it is a really difficult thing to measure, that we really need to make sure that there's a lot of labs around the country that can do this well. And actually, we should really focus on the people who could really benefit from knowledge of their Lp(a). And so we basically identified a few specific groups of patients that we thought should have their Lp(a) measured, and I'll list them. So the people that are included in the guideline are those who either had premature cardiovascular disease in themselves or have had a family member who suffered with premature sort of early onset disease. So that was the first group. And then we thought about patients who've got familial hypercholesterolemia. So those are people, patients with FH tend to have higher Lp(a) levels as well. So that was the second group. We also thought about people who have aortic stenosis. So there is some link with Lp(a) and narrowing of the aortic valve. So we thought it would be useful to know the level in those patients as well. People who have family members who have very high Lp(a), and then those who are kind of in that borderline range in terms of their cardiovascular risk, where if you knew what the Lp(a) level was, that would really help you decide about other treatments. So that's sort of who we thought that it would be useful to measure it in. And then I guess the practical bit is what to do with, when you know the level, what to do with that result. And from that perspective, you know, we basically tried to summarize all the evidence that there is for various treatments of Lp(a) lowering. And I think Dr. Neely and I'll go through this in a little bit more detail. But essentially, at the moment, there are no sort of robust treatments that can really sort of robustly lower your Lp(a) levels. So a lot of the work that is done is around trying to manage other risk factors, and predominantly the LDL cholesterol level, lifestyle, smoking, blood pressure, and those other things. But we can talk about that in a bit more detail later.
So, Dr. Neely, can I just ask you to speak up a little, please, because there's somebody asking if you can do that. So they obviously can't hear you very well. So if you could just talk through what can we actually do about it?
Can you hear me well at the moment?
I can hear you, yes.
Yeah. So yeah, just to follow on from what Jay said, it's important just to emphasize that point about it. How we measure it is really important. It used to be considered that you could measure it in terms of the amount of cholesterol that was in it, or the total amount of mass of the LPA in the blood in terms of all its components. But we now believe that the best way is to actually know the number of particles of LPA in the blood. And that seems to be more important than, say, the amount of cholesterol that's being carried on there, although that might be quite useful as well. But we do know that each LPA particle, because it's got this sticky property like Velcro attached to the surface of the LDL, it can also pick up other sort of rubbish in the circulation, including broken down lipids, which seem to actually contribute to make it an inflammatory particle. But the number of particles in the blood seems to be the most important thing. But as mentioned before, the final sort of mechanism whereby lipoprotein A can cause damage to the artery and to the aortic valve is to get deposited, and for it to, if you like, drop its contents onto the artery wall, where cholesterol will build up, and it can set up inflammation because of the other components that seem to be dumped on the artery wall at the same time. So what we therefore want to do is to take all those measures, all those things that we normally address, and anybody who's at risk of heart disease or who has already got heart disease, and try to improve those as much as we can. So that will include things like stopping smoking, managing the blood pressure, lowering the cholesterol, the total amount of bad cholesterol in the blood. We measure the non-HDL, if you like, cholesterol to sort of judge how we're doing on that. But also things like diet, lifestyle, eating the right things, managing weight. So it's a total risk factor reduction strategy. And also, very importantly, using those medications, those treatments that we know are very effective in reducing heart disease to the best of our ability, even though we aren't necessarily going to stop the lipoprotein A being sent out by the liver. We'll actually reduce the amount of damage that's caused in the artery wall as a whole. I mean, obviously, the future we hope will hold treatments that can actually stop you producing the sticky particles in the first place. But until we're able to do that, we want to improve the health of the artery wall any way we can through treatments that we know are effective in doing so. So that's what we do about it. And of course, as Jay has already mentioned, because it's an inherited trait, something that you will share with your close family members, that you have inherited from your parents, you may share with your siblings, you may pass on to your children. We need to recognize that and then think about not only the lipoprotein A measurement in those other family members, but also address their risk factors, you know, because we highlight that as a family at risk, not just as an individual at risk.
Dr. Cegla, anything to add to that?
No, I think that's excellent. I mean, I think, you know, as Dr. Neely said, at the moment, you know, that is our best strategy. I think, you know, there are studies looking at certain treatments that can modestly reduce Lp(a). But actually, you know, what we're really hopeful for the future is a treatment that's really selective and specifically Lp(a) lowering. And that will really kind of be the proof of the pudding that if we lower the Lp(a), we know that, you know, we potentially, hopefully, are able to reduce the risk of heart attacks and stroke.
Excellent, excellent. Thank you. Dr. Neely, you mentioned about checking family members.
Yeah.
At what age would you do that?
Well, that's a difficult question to ask right now. I would say that we should think about it when they reach adulthood. I mean, there's if there's an opportunity to measure lipoprotein A in somebody who's you know, hitting, you know, 18 or something because their parents had a heart attack in their mid-40s, we should not delay. We should take the opportunity because that opportunity might not arise again. But there is no set age that we could say that, you know, treatment might begin. For any individual, we know that the sooner intervention to reduce those risk factors we talked about begins, the bigger the impact of those measures. So stop smoking right away, sort out the diet right now, you know, keep on top of diet and lifestyle, be healthy, and emphasize the importance of wellness, you know, lifelong. Whenever it comes to the point where, you know, treatments might be considered, it could be at a later age, maybe 40 years of age, for instance, to think about, is there a role for a statin in this individual? And that will often be guided by what has happened to other family members. If somebody's had a heart attack at 38, you don't want to wait to 40 before you start doing something about it. And that's what the philosophy we apply for familial hypercholesterolemia as well. But we certainly want to put in place all those measures that we believe will be beneficial at the earliest possible time, as soon as we're able to make a decision. But on the other hand, we don't want necessarily to start medication people who may not actually be at risk of any damage or serious damage for many years to come. We need to make those decisions based on all the information in an individual patient to make a judgment on that. So it's on a case-by-case basis, really.
Excellent.
But in terms of measurement for a family, I think if somebody's identified in a family with an early heart attack. We mentioned the idea of somebody having a heart attack at 45. Well, first priority is to check their brothers and sisters who are in the same kind of age band as them, and they may be the next people who are at risk. And then the next, if you like, level would be children, for instance. But we don't want to overly worry them, but we want to make sure that they understand that somebody has to be very careful to look after themselves well, with a view to maybe thinking about, is there a role for treatment in the future?
Excellent, thank you. Okay, so I think we'll move on to the questions. I've got a lot of questions here from the helpline, as I mentioned earlier, and for those of you who have also submitted in advance, some of which I think have been answered, but I'm just going to pick up a few. I'll start with, is it true that statins used to lower cholesterol actually raises LPA? Dr. Neely, I'll come to you for that.
Yeah, this has been talked about for a long time, and I think one of the difficulties is that it may be confounded by the way you try to measure the lipoprotein A. And we know that cholesterol-lowering treatment does alter the size and shape of the particles in the blood. So we're not sure whether the measurements are very easy to compare pre and post treatment. But overall, there does seem to be an effect whereby the liver puts out more particles whenever of lipoprotein A whenever the cholesterol is lowered. Maybe as an escape route for cholesterol, who knows? We don't know. But a slight increase in lipoprotein A has been reported by some people. But the overall benefit still is in favor of controlling the bad cholesterol with the statins, and it certainly doesn't eliminate the benefit that you get from the statin treatment. We know by looking at all the big trials that benefit is still there, regardless of what category for LPA you're in, whether you're at the lowest or the highest. And in fact, in most cases, people who have higher lipoprotein A seem to benefit more in terms of the reduction in events than people who have lower values. And that's probably because people with higher lipoprotein A is more likely to have a heart attack event in future, so they get more to gain. So while we'd like to have treatments that both lower cholesterol and lipoprotein A simultaneously, and we hope we'll have that in future, for now we know what we can do that works would be controlling the bad cholesterol overall. So it's not a showstopper for statins in people with high LPA. Okay, thank you for that. Does a blood test for LPA need to be a fasting blood test? Dr. Cegla?
No, it doesn't need to be a fasting blood test. So the one nice thing about measuring Lp(a) is that actually the levels tend to be pretty constant during your lifetime, and they do go up and down a little bit. And we know that they do go up a little with menopause, but generally, if you're born with high Lp(a), you will die with high Lp(a), and it's something that is reasonably constant during the lifetime, but certainly doesn't need to be a fasting test. So the fasting, just to clear that up, the fasting is to do with the triglyceride part of your lipid profile, and also the LDL cholesterol. And those are the only two parameters that you need the fasting blood test for. The total cholesterol and the non-HDL and the HDL don't need to be fasting.
Thank you for that. So, Dr. Neely, can I ask you, what is the scale of LPA in terms of the levels, and at what point will you treat it? Because we've got somebody here saying that, are they a ticking time bomb? And that's actually a question that we see quite frequently on the helpline as well. So that would be quite interesting to understand the levels when people need to be treated, and how can we help them not feel like they're a ticking time bomb?
Yeah, that's a great question. I often think we should maybe all consider ourselves to be ticking time bombs. I mean, I think maybe I am a ticking time bomb, but maybe for different reasons. But I think all of us may have risk factors that we're not aware of, and lipoprotein A could be one of these important risk factors we're not aware of. Now, the way we divide people up into high and low lipoprotein A is somewhat arbitrary. So, for instance, a lot of the guidelines are based on anybody who's in the top fifth of the population, that's 20% of everybody, has got a high lipoprotein A. So that's kind of almost like just drawing a line. And if we compare the people who are in the highest fifth of the population for LPA versus the people in the lowest fifth of the population for LPA, it actually can show that, yes, there's a contrast, there's a higher risk in that top fifth versus the bottom fifth. But in fact, we know that there's a continuous scale and that the top fifth may start at 125 nanomole per liter in particle number, or 100 maybe, depending on whose measurements you trust. But the people who are above that will start to have a progressively higher risk. Now, if you're in the top 1% of everybody, then you're, at a higher risk again. So it's not just a black and white answer. It's to do with the higher LPA, the bigger the risk seems to be. But particularly once you're into the top 20%, 10%, 5%, 1%, you're getting a ramping up of the risk. Now, at that stage, your risk isn't just to do with your lipoprotein, it's to do with all of the things that make up your risk. Whether you're a smoker as well, whether your triglycerides high, all of those things are important. I think I went unstable there. Did you hear that?
I think we worked out. Yes, I think we worked out what you were saying. Thank you. Just sticking with that to a point. So is it true that if you've got a very high level of LPA and you're over 60, is it unlikely that you will get significant CVD from it if you don't already have existing CVD by this age?
Is that for me?
No, Dr. Cegla, please.
Oh, for me, yeah. Yeah, no, so I think it's a continuum. So you may have other risk factors or other protective factors that have protected you from heart disease until that point. But, the whole point, I guess, is that you don't think of the Lp(a) in its just on its own. It's all the risk factors put together that that decide whether or not you will have that heart attack. And so you might have got to 60. It may be that there is, we don't know if there's silent disease. There's a lot of people who may have sort of silent, what we call subclinical disease that hasn't kind of manifested in an event. So it's not necessarily clear just because you haven't necessarily had that heart attack at 60 that you may not have it, in the subsequent years. As Dr. Neely said, it is a continuum. So even though you have high Lp(a), it really depends on how high that is and what your other risk factors are. So that sounds like a bit of a cop-out, but it's unfortunately it's not just that one risk factor on its own. You really need to think of it as one part of a whole orchestra.
Thank you. That's a good way of putting it. So is there any benefit to LPA or having high LPA, Dr. Neely?
Well, we don't really know. We do know that there is one other species that got high has got lipoprotein A in addition to humans, and that's the hedgehog. So hedgehogs evolved separately. We don't know why, but we suspect there must be some use for that. I used to tell patients that maybe it's because hedgehogs are spiky. Maybe they bump into each other. They don't bleed for so long before it stops. Maybe in the past there was some protection against bleeding events with having high LPA. That's a hypothesis. Nobody really knows the answer. But we do know that there seems to be less risk of type 2 diabetes if you've got high lipoprotein A. So that might be one, if you like, thing on the plus side. But overall, we believe that people who have got moderate amounts of lipoprotein A are at no disadvantage. And the disadvantages really only are confined, as Jay says, to the people who are in the highest categories. And by that, we probably mean, you know, well above the sort of up in the sort of top 10% or something of people. People who have got other risk factors, you know, the lipoprotein A may add to that even at slightly lower values, such as, you know, in the top 20%. So I think that there's not, we don't know enough to say yet whether, you know, there's a disadvantage with having low lipoprotein A, but what evidence we have is that people with very low lipoprotein A are very common in the population, and they seem to be just as healthy as everybody else. So, you know, lowering lipoprotein A would seem to be a good strategy if we can achieve that with a safe and effective medicine.
Thank you. Thank you. And Dr. Cegla, so we've had a couple of similar questions around there being no therapies at the moment, and people having potentially sort of almost zero LDL, but some people being on treatment for some people being on treatment for LDL and seeing an improvement with their LPA. But if they can't improve it, what do they need to do? Is it just manage the other risk factors? And I think you've answered that, but I think I'd just like a sort of yes or no answer, really.
Definitely, yes. It's all the other risk factors and managing those as best as you can. In very specific circumstances, in patients who have very, very progressive cardiovascular disease with very, very high Lp(a) levels, when you try to do all the other risk factors, we occasionally consider things like lipoprotein apheresis, but that really is, you know, a very, very kind of last resort strategy, and that's sort of a dialysis-like procedure that patients have to come in for, you know, once a week or once every 2 weeks. So it is sort of last resort, but generally, you know, it really is managing all those other risk factors as best you can. That's the best you can do for yourself.
Thank you. And Dr. Neely, other than having a blood test, are there any other clues that you may have high LPA?
Not really, except for two things. One is a family history of early heart disease with no other clear explanation for that. So, you know, we find that there are people that have several members of the family with heart disease in their 50s or 40s, and they don't have especially high cholesterol, such as familial hypercholesterolemia. The other thing is, as Dr. Cegla mentioned already, narrowed aortic valves running in the family, and that's another important one, because unlike high LDL alone, having high LPA does seem to have this specific thing whereby the LPA can damage the valve, which is the major artery coming out of the heart, the aortic valve. So that does seem to be linked genetic to the high LPA. So those are the two things I would think of. But basically, it's a bit like familial hypercholesterolemia, where you've double normal LDL from birth. It's potentially a silent killer. We don't even know about it, except we find there are people in the family have early heart disease, and we should think about why is this happening, and should we look for an explanation? If we can't find it in cholesterol alone, maybe LPA is the answer.
Thank you. Dr. Cegla, is there any advance in the knowledge around whether lowering elevated LPA will actually improve cardiovascular risk?
So I think if you ask that question in maybe 3 years' time, we should have hopefully a sort of definitive answer for you. So there are current clinical trials going on where there are treatments that very specifically lower just the Lp(a), and they, you know, those are big trials. There's, I think it's sort of 15,000 people globally who are being involved in those trials. So, and their primary question is, does lowering the Lp(a) actually prevent heart attacks and strokes? And it takes time to collect that data, because you're waiting to see if there's a difference between the placebo arm and the active arm of the study. So we will have a definitive answer, hopefully, for that in a few years. From the knowledge that we have at the moment, there are some trials of other medications. So we know that, for example, the PCSK9 monoclonal antibodies, which are medicines that lower LDL cholesterol, but also modestly lower Lp(a) by, the trials say around 20%, but from our clinical practice, it seems more like 10%. But there are studies that have looked specifically at patients who take those monoclonal antibodies, and they found that those patients with high Lp(a) seem to benefit from that medicine more than people who have low Lp(a). And probably that is because they're at higher risk to start off with, rather than the Lp(a) lowering itself, because it seems to be very modest. But I think that's probably the best we've got at the moment. The only other study I can think of is one that's been done locally in Harefield Hospital. It was published a couple of years ago now, that used apheresis. So as I mentioned, this dialysis-like procedure and they look specifically at patients who have high Lp(a) and angina, and they basically gave people either apheresis or a sham sort of apheresis procedure. And they found that those who had the apheresis to remove the Lp(a) tended to have benefit from their angina symptoms. And when they did heart tests to look at the perfusion and the way that their circulation was, that appeared to improve as well. But the caveat there is that the apheresis doesn't just lower the Lp(a), it also takes out a whole host of other kind of clotting factors and LDL cholesterol as well. So we can't be sure that it's the Lp(a) lowering itself. So I think my take-home message really is that, unfortunately, we don't have a definitive answer yet, but I think watch this space, hopefully 3 years' time.
Okay, well, that was actually going to answer the next question, really. So, Dr. Neely, when will medication for Lp(a) be available and on prescription? But that also goes with hand in hand with another question that we've had. When they're available, are they only going to be available for people with existing heart disease, or whether they've had a heart attack or a stroke?
Well, these medications, like the other injectable medications that Dr. Cegla mentioned, are likely to come in at a cost which is much greater than existing therapies such as statins and ezetimibe. And what we know about treatment decisions made by NICE when they look at new medicines is that they will have to justify the cost in terms of the benefit that's gotten back through reducing risk. So normally the highest risk people are the ones that are the first to benefit from any new medication that comes in at a high cost. So we could anticipate that in the first instance, they're likely to be made available to people who have had a previous heart attack or maybe even recurrent heart attacks. The technology is based on mRNA, a bit like the vaccines, the Pfizer vaccine, etc. And however, in this case, rather than making your body print off a protein, it's actually stopping you printing off the Velcro that makes the protein A. So that technology is potentially scalable and may in fact be able to be produced in future at lower cost than it is right now. We know the vaccines were produced at mass numbers, with very large amounts of people receiving them. And maybe if lipoprotein A is identified as an important risk that can be fixed with this treatment, maybe it'll be more widely used and the costs may fall, and it may ultimately become available to people who haven't had a vascular event in the past. So we can only hope for that. Fingers crossed the treatment costs might come down if it's shown to be safe and effective and therefore more widely applicable.
And Dr. Neely, can you ever see a time when emerging research will result in Lp(a) being dissolved and removed?
Well, all proteins that are produced by the body are dissolved and removed. It's what lipoprotein A dumps on the artery wall that causes the trouble, because cholesterol, once it's dumped on the artery wall, is very hard to remove. And in fact, you can dump broken down cholesterol, we call oxidized cholesterol, which causes inflammation. So it's that, if you like, burn to the artery wall that is the damage. The LPA protein is really just a vehicle that takes some nasty stuff and dumps it on the artery wall. So really, we want to reduce the number of those vehicles that are going out in the first place. I think the body will heal the rest if we can get rid of those vehicles going out all the time.
So there's quite a few questions around what is the optimum level for LPA, and so what is considered high and what is considered a good level, a bit similar to, as we know, with the numbers with cholesterol. Dr. Cegla, I know we've touched a little bit on this, but is it possible to give a sort of definitive level that people should aim to be at?
Unfortunately, it's not at the moment, because we don't know that if we lower it to a certain level, your risk becomes, the same as someone with, average sort of lifetime risk of a heart attack. So we don't know for sure what the optimum level is. All we know is from the epidemiological studies is that as the level goes up, the risk goes up, and that risk, it's not sort of a linear risk, it sort of is a kind of a curvy linear risk. So that the much higher levels, as Dr. Neely said, if you're in that top 1%, then your risk is much higher. And the other thing to say is that the vast majority of patients in of the population have quite low levels of Lp(a), but it's an optimum level, I think, is impossible to say. I don't know, Dr. Neely, if you've got anything to add to that.
No, I think that's what you've said is exactly what I would say as well. I think that what we can say is that if you've got heart disease, we always say that your cholesterol must be too high. We want to lower it to reduce the amount of buildup on the artery wall. If you've got vascular disease and your lipoprotein A is higher than most other people, you're probably going to benefit from having a lower level. But I don't think we can be any more specific than that. Most people would say that you would want to be below the average for the population, it would be a good place to be. But I think, it'll take some time, and the results of this research will actually help us decide, is there a specific threshold level where you want to get below for safety? We don't know that at the moment.
Thank you. Dr. Cegla, there's a cohort who encouraged the use of niacin. Do you agree with this is not sound advice?
Yeah, no, I certainly don't use niacin in my clinical practice. And we did used to use it up till about, I think it was 2012, if I'm not mistaken, when it was withdrawn by the EMA at the time. So there was a big study that came out, the heart protection study, that suggested that actually there was no cardiovascular benefit. There was no improvement in cardiovascular health in patients who were taking niacin, but in fact there were big problems in terms of stomach issues and bleeding. So actually that's why they decided this was probably not a safe medicine for us to be licensed, and they took it off the market. It did, if you looked at numbers, if you looked at the biochemistry, it was good at increasing HDL, and it did reduce Lp(a) by probably around 20%. But I think at the end of the day, those are numbers. What really counts is, are you reducing, heart attacks and strokes, and are you improving people's lives? And that wasn't borne out in the studies, and hence that decision.
Okay, and can I also ask you, Dr. Cegla, about aspirin? Is there any benefit to people taking aspirin?
Yeah, so that did come up in our statement, and we did discuss sort of the risks and benefits of aspirin. So as Dr. Neely mentioned, there is this Velcro-y bit of Lp(a), and we think that makes people potentially more likely to clot. That's not from sort of studies sort of human studies where we've looked specifically at the use of aspirin in patients with high Lp(a), but from studies in sort of Petri dishes, it appears that Lp(a) does increase clotting. So the question then goes, would aspirin help with that? And we haven't, as I said, we haven't got specific studies that have answered that question. There is some sort of retrospective data. So when you've looked back at studies of aspirin and tried to, divide people by Lp(a) levels, there does appear to be some benefit. And hence, I think on a case-by-case basis, we do use aspirin in certain patients, but it really is case-by-case basis.
Thank you. Dr. Neely, for perimenopausal women who have got high LPA levels, is it worth them starting HRT early in order to protect their heart?
Well, it's another great question. And as Dr. Cegla mentioned earlier on, there does seem to be somewhat of an increase in lipoprotein(a) at the time of the menopause. And it may be that there's a modest reduction in that LPA concentration in the blood when hormone replacement or estrogen replacement is started. However, we don't actually have very good evidence that doing that actually reduces the cardiovascular risk. So the studies to prove that strategy is effective just aren't there at the moment. What we do recommend, I think, hormone replacement therapy or HRT for is menopausal symptoms. So I would say that if you've menopausal symptoms and they're relieved by HRT, that's a good reason for taking it. But we wouldn't recommend it for other reasons at this stage in the absence of any menopausal symptoms. So it sounds good in theory. It's a bit like the aspirin question. We unfortunately don't yet have enough evidence to show that there's the benefits of that would outweigh any risks. So I think that's one I would hold that thought for maybe later for studies to come and show one way or the other.
Okay, thank you. Dr. Cegla, does high HDL affect risk if you have high LPA as well?
Oh, that's a good question. So, when we think of the HDL and the Lp(a) as quite separate entities, but in terms of HDL, if we look at the studies of HDL, there's an association with low HDL and cardiovascular risk, but when you correct for other sort of risk factors, that doesn't seem to be so well borne out. And there have been studies over the last 20 years or so of medicines trying to raise your HDL levels to see if that will help you protect your heart, and that doesn't seem to work very well either. So HDL, generally, there is an association with, normal to higher HDL levels being associated with some protection until a certain level. And then when you get very high HDL levels, HDL cholesterol levels, those particles don't seem to function as well. And then that protection is lost to some degree. So if you have very high HDL levels, I don't think you should be reassured by them to try and protect you. And that shouldn't, I've occasionally had patients saying, I don't need a statin because I've got quite high HDL levels. And I think that will protect me. And I don't think that is the case. So the high HDL levels on their own, I think you need to think of them sort of separately from the Lp(a).
Mm-hmm. Thank you. So Dr. Neely, back to you to talk about knowledge of LPA in primary care, so in our GP practices. A lot of people we're hearing on the helpline are having difficulties to get an LPA test. So what's your view in terms of the knowledge of LPA around the UK in our primary care setting?
Well, I mean, lipoprotein A or LPA has had to compete for attention with so many other issues in the last few years, with things like COVID going on. Everybody's obviously aware of cholesterol as a risk factor, and we're becoming increasingly aware of the importance of identifying inherited forms of high cholesterol, such as familial hypercholesterolemia or FH. So I think lipoprotein A is kind of almost like being a little bit of a Cinderella, and most of the GPs that are currently in clinical practice won't have been taught about it in medical school. So they'll only have picked it up afterwards if they've been paying attention to certain, if you like, medical education sites. And they don't all know about it. I think most of the specialists in clinics nowadays are well aware of lipoprotein A and the importance of measuring it, but that doesn't really yet, sort of flow through to sort of primary care knowledge. We're trying to correct that. We're trying to improve that. We think that the best way to get the attention of our primary care colleagues is by, if you like, emphasizing that it's one of the inherited cholesterol conditions we should be thinking about if there's premature heart disease. So as emphasized, as Dr. Cegla mentioned in the statement. But as yet, none of the national guidelines have actually made a big, if you like, sort of statement on lipoprotein, apart from our own Heart UK statement. But NICE, for instance, haven't put it in any guideline. We're trying to correct that going forward, and that will obviously help. Some people have said, well, actually, we're never going to win this battle, and there's a treatment out there, protein A, and it's proven to stop heart attacks and strokes and whatever. And that could be, that could be the case. But we don't think we should wait for those studies to come through in 3 to 5 years to prove that case. We think we need to start recognizing it now and raising awareness. So I think there's a long way to go with this, but events like this we think will raise awareness, and we've put out a nice little supplement in British Journal of Cardiology, which is aimed at GPs and cardiologists, just coming out right now, which is going to educate them as well. So together with stuff we put in the website and all the rest of it, we hope that this will improve things. And the next Joint British Societies guidelines, which are also going to be aimed at GPs and hospital doctors, should also make more of LPA recommendations along the lines of our statement. So it's early days. We've only known about LPA since the 1960s. So, it's not, we've got a bit of time yet. It gets its 100th anniversary, maybe we should start to panic, but we're working as hard as we can.
Thank you. So, Dr. Cegla, I'm coming back to you for some COVID questions, actually. Can LPA cause long COVID? That's one question. I'll give all three to you, actually. Somebody's worried, well, a few people are worried about the AZ vaccine in particular, because it's known to cause clotting. So they're concerned about that. And will people with COVID actually, and LPA, will they be offered the antiviral drugs?
So let's go with one at a time, Jules. So the first one was, can Lp(a) cause long COVID? Yeah. And great question. I don't think I've not seen any publications that have looked at Lp(a) levels and the risk of long COVID. I don't think it's been studied. I mean, you could hypothesize that if you think, if it is Lp(a) is causing sort of microclots, and obviously we know COVID for sure does have that prothrombotic aspect to it as well. There might be some sort of synergy there, but I don't think it's been definitively proven as yet. The next one, Jules?
The next one was, people are concerned about the AZ vaccine because of clotting.
Yeah, no, again, it's a good question. I think I mean, the main thing with COVID is that the main risk factors for COVID are cardiovascular risk factors. So, you know, if you have high cholesterol, if you've got blood pressure, if you smoke, then you're going to be at much higher risk of having serious COVID if you get it. So I think, you know, my advice would be, if you have high Lp(a), to be vaccinated for sure. And, you know, again, I don't think there's any evidence that those people who have had the AZ vaccine that there's any sort of increased risk of having clots if you've got high Lp(a) and have the AZ vaccine. So I think, again, evidence-free zone, but definitely get the vaccine if you have high Lp(a) levels, whichever one there is.
Thank you. And the final question on COVID was, are people with high LPA, being offered the new antiviral drugs?
Not specifically, as far as I know. I mean, the antiviral drugs, sort of certainly in our hospital, are for serious admissions with COVID. But Lp(a) isn't generally measured, so most people aren't aware of their Lp(a) levels. So I don't think knowledge of the Lp(a) kind of impacts on the management of COVID at the moment.
Excellent. Thank you. Thank you both very much. That's actually all the time we have for questions today. So what I'd like to do now is to run the poll at the end to see where we land up. So let me run this. Oh. Excellent, excellent. Okay. I am going to stop the poll there and share the results, which I think is a brilliant place to be. So we were at 45% on somewhat knowledgeable and 68 now, and well, there's barely anything on very knowledgeable at all. So I think we've made a huge inroads on that knowledge. So hopefully everybody has enjoyed the talks tonight, and we just felt that it was the right thing to do in terms of more of a Q&A type of situation, because we have been getting an awful lot on the helpline. We do, as Heart UK, we do an awful lot around lipids generally. LPA, we do have information on the website, and we have done clearly the statement of care. We have conducted an audit across the UK of services for LPA. We have got LPA services on our lipid clinic map. So it shows where there are LPA services. So please do take a look if you are interested. We are looking at producing further education for primary care, but also doing more around patients, obviously. And then at some point, we'll probably have to pick up the political argument as well. I'm sure that will be on the radar before very long. And of course, we have an annual scientific conference that sadly we can't have patients at because of the rules around pharmaceutical funding. But rest assured, it is always discussed at that agenda and has been for a number of years. So hence how we've been at the forefront of publishing our statement and raising awareness and providing the support to people. So thank you everybody for joining us this evening. If you'd like to hear more about LPA and many other things about other lipids too, please do sign up for the Heart UK news. It's absolutely packed with information, loads of recipes and lots of other really, really exciting stuff. And obviously we would really like to continue to providing this type of support for people and patients, as well as healthcare professionals, of course. So I would just encourage you, if you could make any donation at all, please do go to the website, and that would be gratefully received. Thank you very much. And I think that just really says to me that thank you all and I hope you've enjoyed it. This will be recorded, or has been recorded, and we will be uploading or informing you through the e-news. I'll put my teeth in that when it is live on the website. And I think really just to say, I think if we all become hedgehogs, actually that could be quite good. So maybe we come back as a hedgehog. Thank you all very much. Have a lovely evening.
Thank you. Bye.
Thank you. Thank you, Dr. Neely and Dr. Cegla. You've done an amazing job. Thank you.
Pleasure.